Then by the time we finish closing space, now we have class 1 canines. So we leave the screws there just because we just wanted to keep them for retention. And by the time when we want to mesialize and burn anchorage, that time we remove the screws out so we can mesialize the posteriors. So in this case, we were just using it to get the overjet corrected because it's a class 2 case. Then we remove the screws so that we can mesialize the posteriors for correction. Then you can use it even for moving single teeth. Let's say you don't want to retract the whole segment together. If you want to retract just the canines together, you can use it. But for me, this is a waste of a screw. You can use it to try out single tooth movements, but the whole benefit of a screw is to just try to move many teeth at the same time. That's the advantage it normally gives us. So if I have to do single tooth movement, I would rather just bend and do it much faster. There is no need to wait for a loading time. So I'm showing you both options so that you know you have both options for a case. You can either use staging or you can use a sliding mechanics with mini screws. So this is called sliding because now we are basically moving the teeth back on the wire, and we have a closed coil spring which we just activate every month. So for me, I normally don't use the full length springs. If I have to, I will normally use a shorter spring, and I will activate this with ligature wires, because if it's a full length spring, the moment the canine goes back a little bit, you have to replace it with a new one. So it's better to use a shorter one, stretch it with a ligature. So every month you just replace the ligature. So you don't have to keep replacing the closed coil springs all over again. Then you can use it for en masse retraction. So in cases when you have bimaxillary protrusion, now you want to retract everything. So in these cases you want maximum profile change. So there are only two ways to get most times maximum profile change. One is using staged biomechanics, which we've already covered, which is we retract the canines first, followed by the anteriors together, or the other way, when you want to retract everything together at the same time. So we tie up the posterior segment, tie up the anterior segment, place hooks, and place power chains to the screw directly. So in this case, we will just slide the entire anterior segment back here. This is clear? So if we are using these, why do we have to tie the posteriors? Because we are not using posteriors for anchorage. Do we have to tie the posteriors with ligature wires? No? No. Okay, no. This side no. This side is still thinking. That side is too full. No, the reason why we tie this is, again, whenever you do sliding mechanics, right? So even though this is a 1925 wire, when the patient eats, sometimes you have deflection of the wire. If you don't tie this segment, it's much more easier. You will start to see sometimes the premolars start to intrude and the bite opens up. So we are just using it to stabilize the posterior segment, not really using it as anchorage. So if you don't tie this, you will sometimes notice that your premolars start to intrude a little bit and the bite opens. So we tie this here just so that we can keep the premolars, molars set on the plane and not having to see an open bite over there. So that is the only reason we tie it here. So the anteriors we tie because we want to move this back as a segment. Posteriors we tie because we just want to keep them down and not get intruded. Then we can use it for you can use it for intrusion of the segments. So either, for example, you want to intrude one segment, you can place interarticular screws and place open coil springs or power chains. We just link them around the wire. Or for single tooth intrusion, we just place a screw. You can place it between the premolar and the molar on one side, and we use diagonal forces normally to intrude. So it's always diagonal forces to try and intrude this, so that if you place this here, there is good chance this will contact because both are going towards the apex. So we want to keep this here, one between the first and the second molar and one between the premolar and the molar, so that you have diagonal forces which are vertically directed for intrusion. Is that clear? Any doubts here? Any questions here? No? So then again, many contraindications. If your patient, first contraindication, if your patient doesn't have very good oral hygiene, try and avoid meniscus. Because especially plaque causes meniscus to fail very easily. So if your patient has good oral hygiene, then we consider all of these bleeding disorders, diabetes. These kinds of patients, specifically diabetes, it usually fails much faster because the bone remodeling is much slower. So for the others, you can still place it depending on whether the patient is on medication or not. Diabetes, it normally depends on the sugar levels of the patient, but diabetic patients, it's more common to see periimplantitis, more common to see meniscal failure, more common for it to get dislodged very easily when you apply force. Then we have relative contraindications. As I said, first one, poor oral hygiene, smoking, bone problems. If you see the bone quality is not very good, again, maybe better not to consider using meniscus. You can go in for appliances instead. And then just see if you have enough bone depth and quality or not, and any local infections nearby or not. So limitations, again, we can't use it for very young patients. Technically, even before 17, it tends to get lost very easily. So up to 17 years, it says 12, there is no chance we can place one. Above, between 12 to 17, you can place it for a very short term, because the bone is still much more cancellous compared to cortical, so the chances of failure are usually much higher. So it's better to wait for more adult patients if you want to use these. Then you can, for us, what we want to consider is the age of the patient, the quantity and quality of bone which is available at the post site where we will insert, and then the reason basically if we have to. So bone, we already know how to assess using CBCTs, or you can use the depth using the pano first. Then the age of the patient, as I said, it just depends on the site. I normally never, as a rule, use it for patients below 17. Then you also have to check what is the teeth number and existing conditions. So one of the important points for us is that how do you decide the diameter? So the length, we have specific lengths for most sites. We don't change the length much. What normally changes is the diameter. So let's say for the anteriors between the central lateral canine, we normally use 1.4 millimeters. But distal to the canine, between premolars, molars, we normally use either 1.6 or 1.8. So the either or basically means when you place a screw, you should have at least one, preferably 1.5 millimeters of space around between the screw and the nearest root. So 1.5 millimeters of bone around the screw is what we normally look for. Because, as I said, these are not osseointegrated. There is just mechanical interlocking. If you place a chain, if your screw tips even little bit, there is good chance it may contact the adjacent root. So if, let's say the space is lesser, we go for a smaller diameter screw. So we can go with 1.6. If you see the space is much bigger, you can go in with a 1.8, as long as you have sufficient bone around the screw. Is that clear? And then normally we want to have good quality. This doesn't have so much of a difference. So here, so if you look at the implant sites, so there are areas where we can place, where we have 3 mm or more. We have yellow zones between 2.9 and 1.6, and then less than 1.6. So this also helps us decide what size of screw to use. So let's say if we want to place a screw right between the two centrals, you have 3 mm of space, so you can go with 1.4 or 1.6 depending on what is the exact amount of bone which is present. The more you go behind, you will see that the space normally starts to decrease. So if you're going somewhere here, you have to normally check whether 1.8 is feasible or not, or 1.6. Most times 1.6 is the suitable size for posterior interradicular screws. And then again for the lower roots, normally because it's more single rooted till the molars, so there is lesser of a problem in the lowers you can easily go with 1.8, much more easier. And except for the anteriors where it has to be 1.4 is the maximum we can go in the mandibular anteriors. So based on how much space we have is how we decide which diameter to use. So for the maxilla, we have different sides, we have anteriors. If you're using it for gummy smile correction, you can use between 1 or 2 screws and another 2 posterior screws. So basically it's either 3 or 4 screws if you want to intrude the whole maxillary segment. So especially big gummy smiles, maxillary excess patients, we would normally place either 3 or 4 screws. So if it's 3, there would be 1 screw between the 2 centrals. If it's 4, it would be 1 each between the lateral and the canine, and then 2 posterior screws. So you can choose between 3 or 4. I normally, if I have to, I will use 4. I don't use 3 because the middle, sometimes even though there is more bone, the labial frenum bothers the patient a lot. So sometimes patients will come with, it's more easier to see swelling in the frenum around the screw. So for me personally, I will just go with screw between the lateral and the canine. It's less traumatic for the patient. Then for uppers, we also have, this is the position of the screws, normally how we insert. For the lower, again, now it depends on whether we are using it in the anteriors, retromolar pad, or buccal shelf screws. So when we look at, we have a type of screws which we call as infrazygomatic implants or screws. So infrazygomatic screws, normally we use, let's say you have a class 2 patient, you don't want to extract, you just want to distalize the arch. Or sometimes even for retraction, these are very good screws because you have a lot more support here. So the important point here is, one, we have to use much bigger sizes, if you can see now. So now we use 2 millimeters by 12. These normally have a much longer neck, as you can see, and these have to be inserted in a way where we try to go between the 6 and 7. So again, there are, if you look online on, there were 2 protocols. We have one between, if you look at Chris Tank, he will normally place it. There were 2 people who basically pioneered these. One was Chris, one was John Lynn. So Chris normally prefers it right above the 6, he will place it here. Dr. John Lynn normally prefers between 6 and 7, which is here. For me personally, I feel this is a bit more safer. This brings you a bit more closer to the sinus. So 6 and 7 ideally is much more safer to place the screws because ideally you have to go in parallel to the buccal surface of the inside the molar surface, so that you still have space between the buccal surface of the root and the screw, because if you're using it for distalization, if your screw and your root are in contact, you won't be able to move the molars. So there has to be a space between the screw and the root so that you can move it back. So the most common use is for distalization. So if you want to see, basically this is here. We go in first. Do you see how this changed the angulation? So basically go along the buccal surface and just keep going straight up. The good thing about IZCs and buccal shelves is you can almost activate them immediately. So, yes. So, and then we have tuberosity implants. Again, I don't recommend doing this. Especially you won't be able to do it with a straight driver. You need an angulated driver if you want to place tuberosity implants. So before we had the option for IZCs, this is what we used to use long time back, which is tuberosity implants. So the IZCs came much later. So when we had to do full arch distalization, we would just remove the aids, place the tuberosity implants, and retract the full arch. Then we have these are the general interradicular screws. So these are placed, the most common site that we place this is between the first molar and the second premolar, like the case that I showed you before. This is the most common site for retraction. You have class 2 cases, 5 max cases. This is the common site, and now it just depends on whether you want intrusion or not. So what we do is we normally don't change the position of the screw. As much as possible, we try to keep the screw at the same standard height. I will normally play around with the level of the hooks, because if I want intrusion, I will use shorter hooks. If I don't want, you saw in the case that I showed before, I have the longer hooks. So if I just want bodily movement, I will just increase the height of the hooks to be at the same side. If I want intrusion and retraction, if it's slightly deep, I will just use smaller hooks so that I can retract and get some level of intrusion at the same time. So technically you don't vary the position of the screws. The closer your screws are here, so this is normally at the between the attached gingiva and the free gingiva at the level. If you place this too far low, the diameter of the screw has to go down because the root length is much wider. If you go too far up, because this is free, you will notice it causes the screw to start moving very easily. So as much as possible, I never change the position of the screw. I will just change the position of the hooks depending on whether I want to move back everything completely as it is, or I need intrusion or no. Is that clear? Any doubts or any questions here? Okay. So I'll show you where this is very useful. I thought to show you the case tomorrow, but I'll just explain the case. So we had a patient who came with bilateral transposed canines here and here, and she had crowding in the lower arch. You can see this is her canine. Basically, her canine was lying between the central and the laterals. So if it's here, there's normally a 64% chance that it comes out successfully. Successful in this case means the canine usually comes, but the problem is usually with the laterals. So we also have another guide, which is the root apex. So here we normally check whether the root apex lies in the space between the lateral and the first premolars, on top of the first premolars, or on top of the second premolars. So again, based on that, we decide whether we have to bring this into occlusion. The more this goes towards the red, it becomes a bad idea. So when we checked here, we basically saw that this was more or less in the yellow zone. This was going closer to the end of the yellow zone and maybe at the start of the red. So now if we try to pull this directly, there is much higher risk that one, it doesn't come. Second, it may damage the root of the lateral incisors. So whenever we want to bring canines down, we always correct their inclination, angulation first before we try to move them down. So here we also had deciduous root stumps, so we got the deciduous root stumps removed. Then we placed two screws. So both are interarticular screws that we had to place between the premolar and the molars, so that we could try and correct the angulation first. So we bonded chains on the canines, used threads to the mini screws, and we started to just pull them so that we could just dip the canine heads distally. So 6 months roughly, we could see that the canine is moving here in the space between the lateral and the premolars. Once we saw that this has moved on the distal side of the laterals, so now basically we put auxiliary wires and small, very small night-eye wires to bring the canines down. So this is another 4 months. Now we just put a very small 013 wire. Because our laterals are locked, you can also see that we've placed the brackets upside down. And then by the time the canines come down, now the bite opened up a little bit, so we started to put rainbow elastics and class 3 elastics for the lower arch. So it took roughly maybe about 27 months of treatment time. So tomorrow I think I have the full case to show you where we've debonded the patient already from here to here. But in this case we were using them for direct anchorage to try and distalize the canines. So we have too many purposes of using. You can use it for retraction, for mesialization, for anchorage. When in this case, if I wasn't using screws, would have been very difficult to do this with molars instead, or posteriors, because there is high risk that they would move more easily, because the canines are very high placed. So we have to use additional anchorage. Then we can use it for, again, en masse retraction. As I said, you can use it for en masse retraction for the whole arch. You can use it depending on the type of movement. You can change the height of the hose. Then we also have, as I said, I normally don't like the anterior screws because they normally will go somewhere here near the frenum. So if I had to place, I will normally place it like this. So we have 4 screws, 2 anterior screws and 2 posterior screws. So the anteriors would be always between the lateral and the canines, and then the posteriors is always between the premolars and the molars, or you can even place IZC. So it depends on whichever we want to place. So we will normally place 4 screws for intrusion if it's a coming smile. Do you know why we have a TPA when we use this for intrusion? Big hint. We discussed this last year. Do you remember moment of force? Sounds familiar. Moment of force basically says if you are trying to intrude this segment, you will also get compensatory flaring because the movement is away from the center of resistance. So the TPA here is just to keep control over buccal flaring that may occur, so that we get only intrusion and we don't get buccal flaring. So it helps minimize that, otherwise you have to bend the wire and give torque. So if you have a TPA, it helps here keep control over the posterior segment and it doesn't allow it to dip or flare easily. Is that clear? Then you can use it for intrusion of upper teeth, you can use it for intrusion of lower teeth. So as I said, there are too many options for intrusion, extrusion for bodily movement. So what we do is, how we activate this is normally, if you have to place, you just place a power chain from the screw and we just link it around the wire and we will just hook this onto the mini screw. Roughly about 200 grams of force. Then we also have, do we need palatal screws? I think I showed you one example already. So this is normally we just use it for single tooth intrusion. So let's say you have a patient who came in for an implant. She didn't want to get braces, she didn't want to get ortho treatment, no aligners, nothing. She only wanted to get a crown because she was finding it difficult to eat. So for her, we got an implant placed early, and then we anyways had to wait 6 months before restoration. So we used that 6 months basically to place one buccal screw, one palatal screw, and just use diagonal forces for intrusion, so that we can get a crown placed at a later stage. So these are additional benefits where you don't want to do anything else on the arch, you can just employ screws to carry out. Then you have the palatal tabs if you have to use for any purpose. We also have retromolar pad area tabs. Retromolar pad area tabs, we normally have to open a flap and place first, but again, I don't recommend trying out retromolar pad tabs. There is a much higher risk of failure and the retromolar pad bone is very thin, so it can cause more problems here. Then again, for the lower arch, the favored side is always for retraction. We place it between the first molar and the second premolars, and then you can place this with hooks for retraction of the lower segment. So it's the same side as the uppers, but just between the lower and premolar and first molar. Then we can also use it between, I think this was an example I showed for, yes. So in this case, we basically used it between the lower canine and first premolar. So we had a patient who came in with asymmetry. So he had, you can see his mandible had shifted one side. So for us, one of the problem was he was class 3, so we had to plan treatment for him. He had lots of decayed teeth. Then we also had to jump his bite. So we basically decided to separate his dental treatment from his skeletal correction. So because he was a class 3 patient, so we wanted to expand the upper arch, and then if we start to expand the upper and the lower, we really don't have much to correct his bite along with his asymmetry till much later, till we are on much heavier wires. So what we did for him was, again, this is his pre-treatment facial as well as self. So this was his asymmetry. So whenever he was opening, this was just becoming worse. So when he opens, this slides more towards one side. So we also had to try and correct his asymmetry. So what we did for him was we placed 2 mini screws. Again, one between the canine and the premolar on one side, one between the canine and the premolar on the other side. And then we basically decided to separate his treatment into one dental correction and skeletal correction. So the dental correction was just leveling alignment, we were moving teeth normally. For skeletal correction, we started with elastics directly from one screw to the other because we had to change the mandibular position. So basically it looked like this. So we have one screw here, and the elastics we were using were 5 by 16 4.5 ounce elastics directly from here to here, so that we could try and get correction for the midline. So if you see here, when we started out, his midline is almost here, one tooth towards the right side. Within about 2 months, 3 months, we were able to get it to almost here, and some more months is almost on. So we just continued with his dental treatment separately and his mini screws separately, so that we can start to correct his mandibular shift. But again, this depends on whether it's just a shift or is it skeletal asymmetry. If you have different lengths of condyles, if there is no change in the patient opening, closing, smiling, there is no point to do this. In his case, it was just becoming worse when he was opening and closing, it was coming back. So we knew that this is a case of a shift. So we decided to start using screws to correct the shift for this patient. And this is, once we were able to correct his midline almost, you can see his midlines are coincident. And this is his profile after the bite jump. So then we have too many options for screws. You have triangular head screws, you have tissue stoppers. There are too many types of screws. As long as you use any good quality of screw, normally it's fine. So you can use it for mesialization. I think we had a question before for using mini screws for mesializing. So you can use any screw here. These are already prefabricated arms that we get. This basically is tied with a ligature to the tube here, and then all we have to do is just change the closed coil springs here. So this will basically just mesialize and independent of the rest of the movement that is taking place. So you can use any screw here. You can just order, these are ready-made attachment arms. These are tied along with the tube with the ligature wire, and then you can just use a closed coil spring to mesialize the molar here. So there are too many uses we have for screws. So what we have to consider is basically the sites which are safer for placing screws, which are more favorable for us for placing screws. So the green sites are the most favorable for us in terms of the map. These allow us to place bigger diameter screws, bigger length of screws, so it makes just life a bit more easier. Now, if you remember in the beginning, we talked about using self-drilling or self-tapping screws. So either you can use self-drilling screws where you can directly place them. There is one option where you can use a pre-drilling method where you have a pilot drill and very low RPM of less than 30, and then we just insert the screw manually, or we use a pilot drill method where we have a small round fisher burr and then we use the pilot drill to place the screw. So there are all options depending on what you are more confident with. So the process is, again, you make the patient rinse with Chlorhex first, apply topical anesthetic on the site for anesthesia. For me, normally, if it's one ampule, I will use between maximum 1/3 for a screw. If I have to place 4 screws, it will basically be one ampule plus a quarter of another. Because if you place too much anesthetic in the area where you are about to place the screw, also it fails. So normally just about quarter of an ampule is more or less enough. Maximum 1/3. That is enough to numb that area. Don't put the whole ampule because it will just cause screw failure. So you don't want too much anesthesia there also. So just apply a little bit of topical, put a quart or maybe 1/3, and then just wait for about 5-10 minutes till you see that it's flattened. You don't want to see a swelling there, because if there is a swelling there, that means the tissue is still separated from the bone. So when you try to place a screw at that time, you will notice if you let the patient go home and come back after 1 month, you will start to see tissue overgrowth already, which will again cause a higher risk of failure. So ideally, as much as possible, just make sure, wait for 5-10 minutes till the anesthesia swelling goes down, then you start to place the screw when you see that the gingiva is flat again. Okay. So insertion technique, normally these are the steps which we follow. So first thing, there are 2 or 3 steps that we have to follow. One, we mark an area or the long axis of where we want to place a screw. So what I will do is, normally I will place an explorer or a probe. I just place it at the long axis because this will help me decide whether I have to place my screw more mesial, more distal. So I will just mark this first. Second, I will mark my point of insertion. So I will mark these first visually. Then I normally use my intraoral mirror, the one which we use for taking photographs. So I normally ask my assistant to hold that for me all the time. So because especially for the uppers, you will do this in indirect vision. So you need the whole view. You can't place it. It hurts. I had flu the other day. I tore the muscles on my ribs basically by coughing. So it still hurts every time I laugh and I make jokes. It hurts. So what we do is we place an intraoral occlusion mirror. You have a point of insertion, you have a long axis, so you basically have to let your assistant hold it all the time, and then you only are responsible for holding the driver and inserting this. So I will show you how to hold this, how do we place this in the hands-on session. And then we place this with the outside part, the head outside the ginger. Then for me, I will just, once I place this, I will just gently check if there is any primary stability or not. Primary stability means if you see the screw shaky a little bit, that is the best time to just withdraw and reposition. You don't want to send the patient home with a shaky screw, because there is good chance if the primary stability is not there, it will fail. If the primary stability is there, usually after a month, you should have much better secondary stability also. But if you don't have primary stability, better basically to reposition the screw at the same time. You can position it a little higher or a little lower depending on your site of insertion. So here, any doubts here, any questions here? So again, these are very useful to use. We can use it for multiple purposes. And then now we'll go on to the hands-on session where you can try these yourself.